Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Weill. This episode features Dr. Eileen O'Reilly from the Memorial Sloan Kettering Cancer Center in New York and Dr. Naureen Starling from the Royal Marsden Hospital in London. They will be discussing emerging strategies using PARP inhibitors that hold promise in the treatment of pancreatic cancer. This episode is part of a larger educational program titled PARP Inhibition in the Treatment of Pancreatic Cancer, Current and Future Perspectives on Personalized Therapy. For more information on the experts, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this interesting and important topic.
Okay, so I'm Dr. Naureen Starling. I'm a consultant medical oncologist in gastrointestinal cancers, the Royal Marsden in London. And I'm joined today by Dr. Eileen O'Reilly, who is also a consultant medical oncologist and expert in the field of pancreatic cancers, based at Memorial Sloan Kettering Cancer Center in New York. If I just get the ball rolling, Eileen, could you describe the current state of play PARP inhibitors in pancreatic cancer?
Thanks, Noreen. Very nice to be here today with you to discuss this topic. Yes, so just setting the scene for what's going on with PARP inhibitors in pancreas cancer in the US. We have an FDA approval for olaparib as a maintenance treatment for patients with platinum-sensitive BRCA1 or BRCA2 germline mutated pancreas cancer, where they've had stable or responding disease. Olaparib is indicated as a single agent, and that's the current state of play. Be good to hear how things are in Europe and in particular in the UK.
I can certainly talk to the UK. So currently we don't have access to olaparib as a maintenance therapy, as you've described, for pancreatic cancer. I understand that it was meant to be going through our approvals mechanism through NICE, but that hasn't yet come to fruition. So at the moment, because we don't have access to the PARP inhibitor, we also don't have routine access to the germline BRCA testing, which I'm presuming, Dr. O'Reilly, you do.
Very much so. So germline testing is considered standard of care. And in most people's minds, that would include a panel of genes, including BRCA1, BRCA2, ATM, the Lynch genes, etc. in pancreas cancer. But also, it's all considered routine for those who are candidates for treatment to do next generation sequencing and somatic testing. And here, for our discussion today, looking beyond germline BRCA1 and BRCA2, so somatic alterations, PALB2, and other HR gene mutations in the tumor to see if there may be a role for a PARP inhibitor. This would be on an experimental basis beyond the current FDA-approved indication.
I think that is the right direction of travel for pancreatic cancer patients who to date have had rather limited treatment options, and understanding and identifying molecularly defined subgroups for additional approaches that may benefit patients in terms of overall outlook. What I would love to see within our healthcare system and other healthcare systems is that routine panel-based germline testing to identify, as you mentioned, BRCA1 and BRCA2, but potentially other genes involved in DNA damage response that may confer that sensitivity to platinum and PARP inhibitors. And I also think you make an important point about, and I know it's in the NCCN guidelines, again, about that sort of more efficient multiplex NGS approach to look at additional targets in the tumour that, again, might identify patients who have this more BRCAness phenotype. I know some don't like to use that phrase, or HRD phenotype, that again might identify a group of patients for platinum or PARP inhibitors. So to that point, what proportion of patients could fit in this umbrella of either germline BRCA or an HRD type of phenotype?
Thank you. Yeah, so if we think of the core HR genes, and here talking about germline BRCA1, BRCA2, and PALB2, and if you include their somatic counterparts, probably gets close to 8 to 9% total. And then there's another group, which would be kind of the second or third tier, as one might consider them, that could have potential for benefit for this class of drugs. And that might include things like RAD51, C, D, ATM is, potated as a HR gene. Whether it truly predicts for benefit to a PARP inhibitor, I think is open for discussion. CHEK2, for example, BARD1, NBN, so a host of other genes, but we really need to understand more thoroughly whether they are in fact predictive biomarkers for response. I think at best it is speculative at the current time. And to your point, we're hoping that there might be a group of people beyond the subgroup that we know, but I think that really remains to be proven. And that actually, I think, gets to the topic for discussion today. Where are we going in the field of PARP inhibitors beyond the current indications? And I'd love to hear your thoughts, just what you see happening in Europe, and then maybe I can speak to what's going on in the US.
Yeah, so, I mean, in terms of just picking up on the point about, the breadth of, what subgroup of patients may be responsive to PARP inhibitors, including beyond BRCA, there's some nice data from the Glasgow group to suggest that perhaps that's somewhere like 20-25%. But you're absolutely right. What's the predictive potential and what do we see in clinical trials? So to platinum sensitivity, I think within the UK, we're running in the UK from the Glasgow group, Janet Graham, a study of first-line platinum-based triplet versus doublet chemotherapy, a large trial which has a prospective biomarker plan embedded to understand if they use the signatures that they've identified for HRD previously, can they distinguish patients who are more platinum sensitive to direct therapies when we have a choice in terms of the chemo agent. But I think that also talks to the development of PARP inhibitors in the field. I mean, I think one area that's caught everyone's attention, not just in pancreatic cancer, but in other cancers, is that these tumours with DDR defects also seem to have an immune-inflamed environment. They seem to look immunogenic. And so then that opens up the possibility of adding in immunotherapy, for instance, anti-PD-1 agents to PARP inhibitors to see if we can leverage that and galvanize responses or disease control further. I mean, what trials do you see developing in that space?
Yeah, I think this is a really important topic in this field. And as you said, there's a lot of preclinical and indeed some clinical data suggesting that these tumors have more neoantigens, more targets for the immune system, higher levels of PD-L1 expression, maybe slightly higher tumor mutation burden compared to unselected or sporadic pancreas cancer. And there are a couple of studies. So, for example, the cooperative group mechanism in North America, led by SWOG, are evaluating the combination of olaparib with or without pembrolizumab, and that's building directly off polo. So in the germline BRCA1 or BRCA2 group, that's one study. Our group and others are looking at the combination, not randomized, in the setting of core BRCA1, BRCA2, PALB2, in a group of patients who have these other HR genes. That's sort of an exploratory evaluation. And then going back to the point you mentioned about platinum sensitivity, there may be a subgroup of people who don't have any of these HR genes by germline or somatic sequencing that can benefit for PARP inhibitors in pancreas cancer. That is being looked at in a number of studies, including one from here with an IO-based combination. The other area I would say that is very exciting, building directly off Olympia, the breast cancer study that we saw the readout and simultaneous publication in the New England Journal of Medicine in the summer of 2021, is looking at olaparib in the adjuvant setting in pancreas cancer. So after patients have completed adjuvant or neoadjuvant therapy. That's great, right? Seeing it moving to these class of drugs moving to earlier stage disease.
Yeah, no, I totally agree. I mean, in this disease where the survival outlook is poor, we absolutely need to leverage additional approaches in the early disease setting, whether that's neoadjuvant or adjuvant. So I completely agree. It's important that you reference their breast cancer. What do you think we can learn from other cancers where PARP inhibitors have changed outcomes, including breast? gynecological cancers, prostate cancer more recently.
Yeah, very much so. We're a little bit behind those other diseases, right? We have to acknowledge that. Everything's harder in pancreas cancer. But nonetheless, I think we've seen a signal here, an important one, and a real one, and one to build on. So that combination with IO, resistance is early and often in pancreas cancer, and perhaps more than the other three diseases that you've mentioned. I think combination strategies are going to be critical to the space to try to get ahead of early emergence of resistance in pancreas cancer. There are a lot of parallels to draw. So, for example, the question of anti-angiogenic treatment and PARP inhibitors is an interesting one. There's a number of ongoing trials in breast and ovary cancer, the bevacizumab story, in pancreas and other solid organ malignancies, looking at TKIs and sidoranib and other agents in that space. I think there's some intriguing data with mTOR and PIK3 CA inhibitors in other malignancies, so remains to be seen if that'll have a role. And I think we're going to circle back on the topic of trying to combine effectively and safely PARP inhibitors with chemotherapy. Now, chemotherapy is still an important and key aspect of the treatment in this disease.
How doable do you think that is? Because obviously, the chemotherapy we use in pancreatic cancer can be myelosuppressive, and some patients can struggle with it. PARP inhibitors on their own, in general, we know that they're tolerated pretty well. There is a degree of myelosuppression. There can be some nausea, but generally patients cope with them well. But historically, when combined with chemotherapy, it can be tough. I mean, obviously you've run trials in this space in the past. What's your view?
Yeah, I think not straightforward, and one will have to sort of be creative, or the field will be, I think, with dosing and scheduling to see if they can be combined with ongoing studies with platinum, ongoing studies with topo-1 inhibitors. And that's also, I think, very intriguing given the DNA damage impact of that class of drugs. That's probably a bit underappreciated in terms of the importance of that class of drugs in pancreas cancer. Yeah, so I think traditional dosing of chemotherapy and PARP inhibitors, probably not. We know that already, and that's been tried in multiple disease settings. But I do wonder if one of the next questions in the maintenance space is seeing if we can develop a cytotoxic-based combination with a PARP inhibitor and comparing to a PARP inhibitor, if that would lead to greater durability of disease control and perhaps increased responses. Because we know the hazard ratio is very good for pancreas cancer in terms of PFS with a PARP inhibitor, but we also know it's not as good or as durable as with ovary or breast or even prostate cancer.
In pancreatic cancer, are we always committed to the maintenance space? Where do you see the most potential benefit in the future?
So maintenance therapy is an emerging space in pancreas cancer. I think the POLAR study has been precedent-setting in terms of defining from the patient perspective that there's an opportunity to de-escalate therapy and have disease control for a period of time. I think it's also been groundbreaking in terms of regulatory approval and has set the scene for other maintenance studies. And we're now starting to see some registration intent trials being defined in the maintenance space. One of them being, or at least the potential for guideline change with the olaparib plus or minus pembrolizumab study in the just directly building on POLO that we talked about a little bit earlier. So that's really interesting.
We see maintenance strategies in some other diseases, but in pancreatic cancer, it makes intuitive sense. Often the patients have a large disease burden at the beginning. Often they do need the chemotherapy in terms of that debulking and symptom rescue, but it's quite tough to continue that chemotherapy. So being able to de-escalate to something that is pretty well tolerated and also effective, it seems to me quite sensible and also appealing from a quality of life perspective. What's your experience in terms of the patients you've managed so far on who are, say, BRCA germline mutated and on olaparib as a maintenance therapy?
Yeah, I think it's a very attractive and appealing concept to patients, to families, to us as well, to be able to de-intensify therapy, to have option to an oral consideration. and much more flexibility, and I think overall very acceptable tolerability for most patients. And when it works, it can be terrific. And we've had the luxury now of seeing patients literally for years on single agent PARP inhibitor. And that's not something we're used to in pancreas cancer. So when one sees it, it's not every patient by any means, but it's very striking and very heartening. So that's certainly something that we want to develop. And I think this goes back to our discussion. What else can we do? What other approaches? And I think one of the other areas is other DNA damage repair agents. So whether WEE1 inhibitors, whether ATR inhibitors, or their promise is going to hold going forward. And I think we just don't know yet. We've had some signals in other diseases, just learning again, can we safely combine classes of drugs that have, in particular, overlapping myelosuppression? That is an issue.
Obviously, BRCA1 and BRCA2, this was quite a game changer in terms of the definition of synthetic lethality with PARP inhibitors. Do we see those other strongly synthetic lethal interactions between some of the genes that you've mentioned and other promising agents? What do you think about the ATR and ARID1A story, for instance?
Yeah, I think it's still a very open question. There is a subgroup of patients with pancreas cancer who don't have any of these HR genes who have excellent and durable responses to platinum. And we do think that that group may be a group of patients that may benefit from PARP inhibitors. The big challenge is, how do we identify these patients, and do we have any predictive biomarkers that are going to be able to be validated for clinical decision making? And the closest we have right now is some of these HR genes by their mechanism, but not yet by their clinical validation. And so I think time will tell. And it may be that other tools that we can use to identify homologous repair deficiency, whether it be signature 3, whether it be looking at whole exome or whole genome, maybe that'll be in the clinic in a few years on a more routine basis, who knows? That may be a way to tease out this subset. I think we still have a lot of work to do, though, in this space.
It's so exciting to see molecularly targeted therapies now gaining some traction in pancreatic cancer. What we've discussed today is all the potential for combination therapy and approaches based on rational scientific principles. As you say, there's lots to be defined and clinically validated, but it's so good to see so many things in the pipeline.
Yeah, absolutely. Thank you. I really echo what you said. And, these are small subsets, but they're important subsets, and they're an important reference point to build upon in pancreas cancer, which has been, as we know, a difficult field in terms of targeted approaches. But there's now some clear hints here with validation in the context of a phase 3 study to expand. So thank you.
Thank you very much, Dr. O'Reilly and Dr. Starling, for that interesting discussion. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, PARP inhibition in the treatment of pancreatic cancer, current and future perspectives on personalized therapy, and to download various components associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.